Assalamu alaikum, everyone. Today we're going to start our Zoom meeting, the weekly meeting. Welcome, everyone. And we're going to go over the agenda. Dr. Sulafa will lead the meeting. It's up to you.
Assalamu alaikum. This is Sulafa Mahmoud. I'm going to host today's meeting and on behalf of the RED team. We have 4 topics to present: CKD in older adults, emotional intelligence, resident wellbeing, and infographic using Canva. We're going to start with CKD. Dr. Tarig, if you are ready.
Hello, you are hearing me?
Yes, we can hear you. Yes.
Okay. Hello, Dr. Nader. Hello, everyone. Today I will present a topic regarding kidney disease and disorder. Me and Dr. Mutasim. Our objectives today, we have to know and understand how age-related anatomic and hemodynamic and hormonal changes affect kidney function. The most practical method. Yeah.
Sorry to interrupt. Do you have slides to go over or no?
I didn't share my screen. I'm sorry.
Oh no, that's fine. I just want to make sure. Thank you.
Yeah, I have a slide. Yeah, I have. Okay.
All right.
Yeah. It's okay now?
Yes. Thank you so much.
You're welcome, so our objectives today, we have to know and understand how age-related anatomic, hemodynamic, and hormonal changes affect kidney function, and the most practical method of monitoring kidney function in older adults, how to recognize and manage kidney disease and disorder that most common in older adults, at what point patient with chronic kidney disease need referral to a nephrologist and renal dietitian. Topic covers today the aging kidney, what's the physiological change with aged kidney, electrolyte disorders, nephrotic syndrome, renovascular disease, acute renal failure, chronic renal failure, and end-stage renal disease. Regarding the decline in kidney function with aging, first of all, regarding the glomerular filtration rate, it will decrease with aging. This increases susceptibility to acute and chronic kidney disease. Another thing is sodium conservation. There is decrease in distal tubular sodium reabsorption, and also there is decrease in renin and renin activity and aldosterone as well. This increases susceptibility to hyponatremia from salt loss caused by excessive diaphoresis and also by GI loss. Renal concentration capacity also reduced with aging. This lead due to decreased tubular water transport in response to arginine vasopressin release. And the clinical manifestation of this decreased renal concentration is decreased response to hyperosmolar and volume-deprived conditions. There is also a decrease in renal diluting capacity. The mechanism is unclear, maybe due to decrease in GFR, which can lead to decreased response to hyperosmolar and volume overload conditions. Another function of the kidney, which can be impaired also by aging, is acid and ammonium excretion. The mechanism due to decreased GFR. Also increase susceptibility to metabolic acidosis. Regarding monitoring kidney function, the GFR is the most important indicator of kidney function in older adults, and the most commonly used and practical method to estimate GFR is to calculate creatinine clearance using Cockcroft-Gault equations. The MDRD formula, which is modification of that in renal disease, have not been validated in adults more than 70 years, and it's unreliable at extreme weight and extreme age. Determining the actual GFR by performing 24-hour creatinine measurement can be useful. This is how to monitor the kidney function. Well, regarding the electrolyte disorders, the precipitant of osmolar disturbance and can lead to electrolyte disorder is the following. First of all, decrease in thirst sensation. Decrease in thirst sensation also impair access to fluid and or sodium. Fluid, sodium loss from diarrhea or vomiting or diaphoresis. This can lead to hyponatremia. Volume and pressure change related to surgery. Increased fluid intake also can lead to volume overload and hyponatremia. Medication which can lead to diuresis like diuretics and also sodium and water retention like non-steroidal anti-inflammatory drugs. Condition and medications that can cause syndrome of inappropriate ADH, SIADA. Also, some comorbidities can lead to electrolyte disorder, especially cardiac and hepatic dysfunctions. Recognizing hyponatremia, generally asymptomatic until sodium concentration less than 125 milliequivalent per liter. Brain edema can lead to, which is the symptoms of severe hyponatremia, can lead to apathy, disorientation, lethargy, muscle cramps, anorexia, nausea, agitation, headache, and seizure. These are neurological symptoms of severe hyponatremia. If hyponatremia develops rapidly, there is maybe muscular twitch, irritability, convulsion also can occur. The only manifestation of chronic hyponatremia may be lethargy, confusion, and malaise. Treatment of hyponatremia depends on whether the patient is symptomatic or asymptomatic and whether it is chronic or acute. Asymptomatic patient with hypovolemia, hypovolemic hyponatremia, and also they have hypotension, they are asymptomatic. Isotonic saline to replenish intravascular volume is a treatment of choice. If the patient also is asymptomatic with hypervolemic hyponatremia or SIADA, water restriction plus or minus loop diuretics because he's hypervolemic. In symptomatic patients, treatment by intravenous hypertonic saline.
Sorry, Dr. Tarig, your screen is frozen.
Okay, I will try to fix it. It's still frozen?
No,
Hello?
no, it's working here. Yeah, it's
Okay.
working.
Yeah, okay. Okay, now I will start talking about potassium disorder. Hypokalemia in older adults generally result from renal or gastrointestinal loss of potassium. Also may be due to inadequate intake and treated by oral potassium supplementation in hypokalemia. Regarding hyperkalemia, most common with chronic kidney disease and acute condition that causing acidosis. In minor cases, treatment will be by restricting sodium-rich, potassium-rich foods, discontinuing associated medication which can lead to hyperkalemia, and also use of loop diuretics. More severe and refractory hyperkalemia, we can add sodium polystyrene sulfonate orally or rectally. And if the patient has severe acute hyperkalemia with cardiac toxicity or ECG change, this patient need emergency treatment for hyperkalemia. In emergency situation where potassium levels are extremely high and there is risk of cardiac arrest, we can do one of the following measures to stabilize the patient. First of all, we have to give the patient calcium gluconate, which can help to stabilize the heart's electrical activity. Administration of intravenous glucose insulin, which promote movement of potassium to intracellular compartment. Administering sodium bicarbonate, which help neutralize acidosis that can occur in hyperkalemia. Also administering potassium binding reagents such as kixalate, which bind potassium in the gut and promote excretion of potassium in feces. Administering albuterol by nebulizer or subcutaneously, which promote potassium shift from extracellular to intracellular as well. It's important to note these measures should be used in conjunction with other treatments, such as addressing the underlying cause of hyperkalemia and monitoring the patient cardiac function. Now I will start talking about nephrotic syndrome. Definition of nephrotic syndrome is urinary excretion more than 3 grams of protein per day with associated hypoalbuminemia, hyperlipidemia, edema, and hypercoagulable state. Hypertension and renal failure are seen in about 1/3 of cases in older adults. Can result from primary primary glomerular disease.
Sorry, your camera and your mic are on.
Okay. Nephrotic syndrome can result from primary glomerular disease or from infection, malignancy, exposure to allergic or allergens or medications, or multisystem disease. Renal biopsy is essential for early diagnosis and appropriate therapy for the nephrotic syndrome. Membranous nephropathy, it's the most common nephrotic syndrome in older adults, 45%. Most patients have idiopathic disease, may be related to non-steroidal anti-inflammatory drug use, and malignancy are the second most common cause of secondary membranous nephropathy. About 20% of patients have solid organ tumors. Prognosis for older adults is quite variable and correlate somewhat to the severity of the syndrome. Therapy include corticosteroid, cytotoxic agent, or combination, both of them. Minimal change disease most commonly occur in pediatrics, but can be also in adults. Can be idiopathic or associated with tumors and hypersensitivity reaction, particularly to non-steroidal anti-inflammatory drugs. Has the same clinical presentation in older adults as in young individuals. Acute renal failure, severe proteinuria, low albumin are more common in older adults. Up to 80% of older patients respond to initial therapy with steroids, but the relapse rate is high in older adults, about 33%. Current treatment recommendation include trial of steroid, followed by cytotoxic agent if steroids are not tolerated or ineffective. Another cause of nephrotic syndrome is amyloidosis. For evaluation of amyloidosis, we use a renal biopsy or abdominal fat pad biopsy, stain with Congo red or cephlavin T. Renal tissue should be examined by electron microscopy for myeloid fibrils. Paraproteinemia can be found in 68% of patients with primary amyloidosis. We have to order serum urine immunoelectrophoresis for all older adults with nephrotic syndrome. If findings are abnormal, then bone marrow biopsy to exclude multiple myeloma. Treatment with melphalan and prednisolone can delay progression to end-stage kidney disease. Glomerulonephritis, mesangial proliferative glomerulonephritis, characterized by antibody deposition and increased numbers of mesangial cells, can be seen in IgA nephropathy, Berger disease. Idiopathic IgA nephropathy is rare in older adults, but secondary forms are more common. Another cause of glomerulonephritis is idiopathic membranoproliferative glomerulonephritis, very rare in older adults. This diagnosis should be prompt search for secondary inflammatory cause. Therapy based on the underlying disease. Focal segmental glomerulosclerosis cases in older adults resemble those in younger groups, often result from other glomerular disease or secondary advanced systemic disease like hypertension or diabetes. Some patients respond to steroid or cytotoxic agent, but long-term risk usually outweigh the benefit. Basic treatment principles to correct reversible cause: aggressive control of blood pressures using ACE inhibitors or ARBs and aldosterone antagonists. Optimally control blood glucose, treat hyperlipidemia, minimize proteinuria, aggressively manage phosphorus concentration, and moderately restrict dietary protein. Now I will talk about the renovascular diseases. We have to suspect the patient has renovascular disease or renal artery stenosis in case of new onset diastolic hypertension despite the maximal dose of 3 antihypertensive medications, abrupt worsening hypertension that was previously stable, azotemia induced by treatment with an ACE inhibitors or ARB, and also hypertension accompanied by widespread vascular disease. Diagnostic tests for renal artery stenosis, the renal artery duplex ultrasonography, CT angiography, or magnetic resonance angiography, MRA. Treatment of renovascular disease, therapy based on aggressive management of risk factors, antihypertensive regime should include angiotensin blockage, renovascular angiotensin blockage like ACE inhibitor or ARB. Renovascular angioplasty plus or minus stenting carries significant risk because it is more invasive, particularly in patients with abdominal aortic atherosclerosis. To limit invasive procedures to patients whom medical management has not controlled blood pressures, those who develop heart failure, and those with progressive decline in renal failure. In those cases, you have to use the invasive procedures like angioplasty and or stent. Regarding the renal failure, I will talk about acute renal failure, then my colleague Dr. Mutasim will follow by chronic renal failure. More than half of patients with acute renal failure are more than 60 years. 3 primary causes, whether it is perirenal, intrinsic renal, or post-renal acute renal failure. BUN to creatinine ratio generally helps to determine the cause but may not always apply in older adults. Age is not important prognostic factor. Dialysis should be promptly initiated to treat uremic symptom and to prevent complications like infection, heart failure, or bleeding. Perirenal azotemia, hypovolemia is a major cause of perirenal azotemia in older adults. Can also be caused by or exacerbated by ACE inhibitors, ARBs, non-steroidals, and alpha adrenergic blockade. Reduced cardiac output, most commonly from exacerbation of the heart. All this can lead to decreased renal perfusion and also perirenal azotemia. Prompt treatment of underlying cause is critical because restoration of perfusion often results in recovery of the renal function. If treated promptly, it can be reversible. Intrinsic renal disease or acute tubular necrosis, when there is ischemia, ischemia is the most common cause of in older adult. Evolution of perirenal azotemia to frank at 8 tubular necrosis is more common in older adult with acute renal failure, 23% cases, than in younger adult, which is 15%. To distinguish between perirenal azotemia from established acute tubular necrosis, acute tubular necrosis depends mainly on analyzing urinary electrolyte and urine osmolarity and careful inspecting urinary sodium and muddy brown cast. Treatment of patients with acute tubular necrosis generally supportive management. Here's a table how to distinguish between perirenal and acute tubular necrosis. Regarding urinary sodium, urinary sediment, it's hyaline in perirenal and muddy brown cast in ATN. Specific gravity is high in perirenal and low in ATN. Urinary sodium less than 20 in perirenal and more than 40 in ATN. Fraction of excreted sodium less than 1% in perirenal and more than 2% in ATN. Fraction excretion of urea less than 35% in perirenal and more than 50% in ATN. Osmolarity of the urine is high in perirenal and low in ATN. Urine plasma creatinine ratio more than 40 in perirenal and less than 10 in ATN. Plasma BUN creatinine ratio more than 20 in perirenal and less than 15 in ATN. Intrinsic renal disease, acute interstitial nephritis, one of the causes of acute renal failure. The predisposing factors may be medication like non-steroidal anti-inflammatory drug, ACE inhibitors, and also more than 40 types of medications have been implicated in acute interstitial nephritis. Commonly implicated antibiotics, including beta-lactam antibiotics, particularly methicillin, fluoroquinolones, particularly ciprofloxacin. Treatment include discontinuing the offending agent. Rarely, short trial of oral corticosteroid may be necessary when interstitial nephritis is severe. Acute glomerulonephritis also can cause acute renal failure. Rapidly progressive glomerulonephritis, most common form in older adult, may have systemic, related to systemic vasculitis. Consider in patient with acute renal failure and fever, weight loss, arthritis, abdominal pain, myopathy, cardiac disease, or central nervous dysfunction. Therapy include steroid, cyclophosphamide, and plasmapheresis. Diffuse post-streptococcal acute glomerulonephritis occur in 22.6% in patients more than 55 years old. The prognosis is generally favorable. Post-renal cause of acute renal failure due to renal obstruction, a common and often treatable cause of acute renal failure in older adults. Typical symptoms of urinary tract obstruction, such as urinary frequency and voiding difficulties, may not be readily apparent in older adults. Careful review of medication, especially anticholinergic agent, can be useful. Renal ultrasound and measurement of post-voiding residual urine volume may be necessary to establish the diagnosis of post-renal obstruction. Bronchological evaluation is warranted in case of documented urinary tract obstruction, like urinary catheterization. Now I reach my conclusion, and Dr. Mutasim will continue chronic kidney disease.
Well, thank you, Dr. Tarig. I'm going to continue. Can I share my screen?
Yeah, you can start sharing.
Just stop sharing, and then I'm going to share my screen. One second, guys. So Dr. Tarig, I cannot share my screen because you're still sharing it. Hello?
Hello, Dr. Mutasim.
Hi, could you stop sharing screen?
Yeah, I'm trying to stop sharing it. Yeah.
Yeah, thank you.
It's okay now?
Yes, sir.
Okay.
Hello. Hi, I'm going to continue talking about renal problem in elderly. Continue with chronic kidney disease. As we know, whenever someone have an acute kidney disease and this acute kidney disease doesn't resolve within the consecutive 3 months, we put the diagnosis of chronic kidney disease. And the chronic kidney disease in elderly has many causes. It could be extrinsic, like Dr. Tarig told us about glomerulonephritis and infection syndrome, and also interstitial renal disease, and also post-renal like obstructive uropathy, especially in men elderly regarding prostate. And it could be prerenal, especially if someone has sepsis and or any cause that's depleted the volume that increased risk of intrinsic renal damage. And the kidney function, by say in elderly, it's prone more to chronic kidney disease for many reasons. By age-wise, whenever someone is above 40, the GFR is gonna decline by 10% every decade. So if someone is his baseline is 90 GFR, in the age of 60, his GFR will be 60. So P by 40 is in stage 4 GFR. And also the other cause, it could be glomerulosclerosis. And we know that with elderly people, they have fibrosis of the kidney, which is maybe a risk to chronic kidney disease. And also the chronic illnesses. Most elderly people, they are prone to have chronic illnesses like hypertension, diabetes, and they have a lot of arthritis and arthropathy, and they tend to use many analgesia, which is put them in the susceptibility to develop chronic kidney disease. And the manifestation of chronic kidney disease in elderly, it's may present by precipitation of the own condition. If someone have diabetes, then become poorly controlled, this may be a sign of chronic kidney disease. Also, if someone have heart failure and become have a persistent symptom of heart failure, which is maybe or develop a decompensation, which is maybe a sign of chronic kidney disease. And also some of them may have an cognitive dysfunction, like if someone have a dementia and his condition has become deteriorated, it's possible it may be due to chronic kidney disease rather than the main cause of other cause of dementia. And estimated from NHC, which is a National Health and Nutrition Examination Survey, that 6.6 million of people above the 60 years old have a CKD. And this incidence is vary from insanity to different insanity. So the Black, African, and Hispanic in America have grown more wide to CKD rather than the other Native American. Regarding the stage of chronic kidney disease, is similar to stage wherever in each age, it's have a 5 stage, and the stage 3 have P and A. And usually when someone have a stage 4, you need to be follow up with nephrologist rather than the primary physician or pediatric doctor. So principle of management of CKD depend mainly on the symptomatology of the patient, but we have many things to be considered. If the thing that cause the renal failure to be considered to be reversible, we need to take a promotion. Like if someone have interstitial nephritis, we need to stop medication as soon as possible. If someone have membranous nephropathy or glomerulosclerosis or focusing multiple glomerulosclerosis, it may need to control the primary disease, like giving them steroids, cyclophosphamide. And also we need to control the blood pressure, because the blood pressure is maybe a cause of chronic kidney disease or increase the progression of chronic kidney disease. And also we need to some medication to control proteinuria in patient, to adjust the volume, like ACE inhibitor, ARPs, and aldosterone antagonists.
And if someone is diabetes, we need to optimize blood glucose to stop progression of CKD. And also we need to treat others things like hyperlipidemia. And the most thing that's kind of like a little bit difficult to control is phosphorus concentration in a patient with chronic kidney disease. So there are the many morbidity, many diseases that may occur from the kidneys, like anemia, like high phosphorus, like increased atherosclerosis, and increased risk of cardiovascular disease if someone has a progressive CKD. Now, medications that use in CKD, it's if someone have a CKD, and especially if elderly, we need to adjust the GFR, as Dr. Tarig told us before. The GFR here, it does depend on the MDR that's used for a normal person, but here we use an Kirchhoff-Goltz formula for calculation of GFR. If someone has GFR less than 50, we need to adjust the dose, but if it's stage 3B and less, we need to consider adjusting all the medication, especially the following medication like analgesic, benzodiazepine, barbiturate, and other medication like cardiac drugs and antibiotics. We consider some point of management in chronic kidney disease, especially anemia, which is commonly in patients with chronic kidney disease. And anemia in elderly have many causes, maybe needed nutrition, like deficiency of certain vitamins or certain protein, or bleeding loss from GIT problem or whatever. But usually in CKD, it's more related to low erythropoietin. But before we give someone erythropoietin, we need to consider the iron store in that. So we need to check for transferrin saturation. If the transferrin saturation is more than 20, then we start. And if a Medicare have a guideline for giving erythropoietin, because erythropoietin is expensive drugs, so they put a strict guideline for hemoglobin to be less than 12.5 per deciliter, gram per deciliter, and hematocrit less than 39 for erythropoietin. But as I told you, we need to check for other causes of anemia in elderly, like vitamin B12 and iron level. And 50% of patients have 50 of CKD have a dietary problem regarding the iron. And also the elderly people, it's more prone to develop a dietary deficiency of iron, like difficulty in eating, or have dementia, or depression, and other causes of malnutrition in elderly. Other things that we need to adjust in patients with chronic kidney disease include calcium and phosphorus and bone disease in CKD. So whenever someone is stage 4 or less, we need to check for this element, and we need to try to maintain the phosphorus level between 2.7 to 4.9. And also we need to check for PTH. And whenever we have an increased PTH and the phosphorus is not low, we need to restrict phosphorus. And even if the PTH starts increasing more, we need to give drugs that like silvamine and other drugs that chelating out the phosphorus from the body. And if we're giving someone vitamin D, we need to watch for calcium level and vitamin D. And also the patient of CKD are prone to develop osteoporosis, so we can recommend it to give them bisphosphonate, but especially if they didn't have an adynamic bone disease of the bone. Regarding also patients with CKD have a risk to develop depression, so screening for depression in elderly with CKD is warranted. But sometimes it's difficult to diagnose depression in elderly, especially because the symptom of depression, it may present as a symptom of uremia, or if someone in dialysis, it may present symptom of insufficient dialysis. And the only we cannot use the CKD CAP as a screening tool for elderly. We need to adjust some tool for screening depression in elderly people. And if someone we make sure this symptom is related to depression, we can start them in low dose of SSRI, especially citalopram and sertraline, which is not a long acting like fluoxetine and paroxetine. So if someone we suspect to have a depression from chronic kidney disease, we can start him in low dose SSRI as citalopram, sertraline and citalopram. And nutrition in CKD, it's difficult, especially we need to restrict main dietary elements. So if we have someone, we have a CKD stage 4 or less, we need to refer them for nephrology dietitian, because we need to adjust the protein to be 0.6 up to 5.7 and also we need to restrict phosphorus to be from 0.8 to 1 gram per day. And as I said, there's many problems regarding nutrition of elderly, especially age-related factor, lack of transplantation, low income, and loss of social and family support, also loss of teeth and impaired sensory function, and also using of medication, which is may have a side effect like nausea and vomiting, which is may aggravate a nutrition deficiency in elderly. End-stage disease. If someone has GFR less than 15, or if anyone that requires dialysis for long term, it's by definition is end-stage renal disease. And more than 55% of patients with end-stage renal disease, their age is 60 or more. And there is many increase in renal replacement therapy, which is may help a lot of people, but increasing in remaining life expectancy with attendant to progression of CKD. So if someone we give them supportive treatment during the CKD, they with increasing the life expectancies may prone them to develop a CKD. Hello?
Yeah, the slides are freezing. Can you navigate it again?
This one?
No.
Did you see right now or no?
We see the screen, but it's not moving. We are in slide number 25.
25? Sorry for that.
Yeah.
You are here?
Yes,
Can you unshare and then share again?
Yes,
Okay.
exactly. Maybe it will fix it.
Can you see it again? Right now it's obvious for you guys.
Yes, yes.
Yes.
So this is a graphic for it presented from US renal data system in 2007 that showed the chronic kidney disease and the corresponding age. And you see that whenever there is increasing age, they increase risk of CKD in patients. So if if someone is 80, the incidence of chronic kidney disease it's around 1,600,000 of people that in their 80 they have an end-stage renal disease. End-stage renal disease and dialysis. Dialysis age is not on sole exclusion from dialysis, and we have two types of dialysis: hemodialysis and peritoneal dialysis. We need to adjust a type of dialysis according to certain situation, like blood pressure, they have fistula or not fistula, they have someone to bring them to the hospital, they have supportive. So we need to put many things in consideration before starting the type of dialysis. And as we told you, the area referral of to nephrologist to discuss the dialysis is better for the patient. And also if someone have a dementia, we need to consider is this from dementia or from dialysis, especially if we can give them trial of dialysis for 3 to 6 weeks. If they're responding, it may be related to the CKD. If it doesn't, it's this de novo dementia in this person. Effect of dialysis on life expectancy. Dialysis, it doesn't provide a normal life expectancy, but it kind of like provide a meaningful extension of life. And this will give you this comparison between someone in non-dialysis and someone in dialysis. And I don't know if this is normal person or not, but as I studied, it's kind of like the age for non-dialysis normal person. If someone his age is 40, 45, and the expected life, it will be 30 to 40 years. And if someone in dialysis, the life is gonna increase by 6 to 7 and 9 to 7. And for elderly people, they have a life expectancy about 24 months, the median survival for them, if on dialysis. End-stage renal disease and transplantation in elderly, as we say, age is not an exclusion from transplantation. And whenever we have someone that develops a CKD, it's kind of like we don't know the cause, we can consider them for transplantation. As we know, there is a long list for transplantation in US, and I think there are around 60,000 people currently at that time of this. I think it is 2010. They're waiting for transplantation. So, and the transplantation in elderly, it's the one benefit thing that they have a low risk of rejection compared with young population, because I think, in my opinion, it's related to immunity. But the other risk, they have more risk of infection, they have more risk of sepsis, which may precipitate an acute kidney failure in patient who has been transplanted. But family and patient, you need to explore them the option of transplantation when they develop end-stage renal disease. If there is no contraindication, like if someone didn't have metastasis disease or have a permanent dementia, or then we can consider them for transplantation and referral for that. Hospice care for end-stage renal disease. In almost half of cases, if they develop a failure survive and then withdraw them from dialysis, we need to refer them for hospice care. And other studies show that most of the people that refer from hospice care is more than 65. And also, the pediatrician have a rule indicating the nephrologist and the patient about the value of hospice in elderly. And around, in a study done in 2006, around 22 patients on hospice from end-stage renal disease, they die in hospital, but more than 2/3 of them die at their home. And if someone is stop them for dialysis, it takes them for 1 week to 2 weeks. So maybe then this is a life expectancy after stopping dialysis from someone. In summary, as we mentioned earlier, kidney have many functions, but this function is maybe affected by age, regarding the hemostasis and regarding the vascular and many causes, and also salt and water in elderly. The main cause of renal in elderly, it may be related to prerenal azotemia, which is risk to intrinsic renal disease, especially ATN and ischemic type. And the other thing, that serum creatinine is a poor marker for kidney function in elderly. So we used what is called Kortikov rather than the unusual formula using in the normal age. It's kind of the middle age population. And it's classified as the same in 5 stages. And the prominent rule of the treatment is prevent progression from CKD to end-stage renal disease. And as I told you, if someone have a stage 4, you need to be referred for nephrologist for proper management of chronic kidney disease, and also to manage the consequences like phosphorus and others, and a dynamic bone disease, osteoporosis associated with CKD. We have 3 cases. I'm gonna share it with you. The first case is a family of 58 years old man. Just 1 second. A family of a 58 years old man took her AR because bringing her to the ER as has increasingly erratic behavior. Normally, she functioned independently, but over the past few days, she had been forgetful, confused, and disoriented. History includes pneumonia 6 months ago, hypertension, and GERD. Medication include hydrochlorothiazide, omeprazole, lisinopril, and multivitamin. The laboratory results show the sodium is low, the potassium is low, and blood urea nitrogen is normal, creatinine was normal, urine sodium high, and urine osmolarity was normal. And the question is, which of the following is most likely cause of this patient hyponatremia? So we... Hello?
Yes, Dr. Mutasim.
If someone have an answer, or... This question regarding the hyponatremia in elderly, and we have 5 answers. This someone have hyponatremia and hypokalemia and have normal urinary osmolarity, but have a high urinary sodium. The cause will be syndrome of inappropriate ADH secretion, or B, it will be water intoxication. 3, it's related to hydrocortisol that taken. D to omeprazole, and the last thing is volume depletion and poor intake, poor oral intake. What do you think? What do you think this answer is?
It appears as almost everyone picks A.
I can't. It is in chat.
Sorry?
Yeah, I get it. So unfortunately, the answer is hydrochlorothiazide. The cause of a renal injury in this patient. So the answer, if you look, we can exclude it from here. If someone have hyponatremia and hypokalemia, so the syndrome of Amna it will not be, because it may cause hyponatremia, but it doesn't affect the potassium level. And the water intoxication associated with hyponatremia, and also it have a low urine osmolarity, and the urine osmolarity here is normal, so it's being excluded. Omeprazole, it may be associated with sciatica, but in rare case, as I read down there. But the volume depletion and poor intake, it may be a risk, to cause an hyponatremia and hypokalemia, but the urine osmolarity will be very high. So the answer here is hydrochlorothiazide as a cause of hyponatremia and hypokalemia and in this patient. Second question is about 80-year-old woman admitted to hospital with urosepsis. On examination, her weight is 60 and has low-grade fever and increased respiratory rate. They find a consolidation in the right lower lobe. Her lab results were normal electrolyte concentration, but her serum creatinine is a little bit high, is 1.8, which is recent, which is her recent baseline value. And then in response to 2 days of IV antibiotic and culture reveal an E. coli sensitive to trimethoprim and sulfamixazole. Pharmacists remind you that this medication requires adjustment for a patient with renal impairment. So we need to calculate the GFR for this patient. As we told earlier, the creatinine, this creatinine, it seemed to be a little bit high, but if you calculate the GFR for this patient, it will be very low. So if you need to calculate the GFR, I'm going to remind you with the formula, and then you calculate it. The formula of Kortikoff, it's 140 minus 8 times the weight of the patient divided by 72 times the serum creatinine. And then if the patient is female, we need to multiply the lower by 0.85. So can someone calculate the... Hello. So the GFR of this patient will be 23, 24. So the answer is D for this question. As I told you, we will not use a MDRD formula. We're gonna use Kortikoff Gold formula, which is it's 140 times minus 8 times weight of the patient divided by 72 times serum creatinine, and then we're gonna if the patient is female, we're gonna multiply it by 0.85. So it will be this patient will be on stage 24. It's stage 3, stage 4. The last case in our presentation, it's 78-year-old man come to the office because of left knee pain for the past month. He has a history of long-standing hypertension and type 2 diabetes mellitus and ischemic cardiomyopathy and CKD. He on hydrochlorothiazide, metoprolol, lisinopril, atorvastatin, aspirin, and glipizide. His blood pressure was normal, his pulse was normal, his left knee is tender for palpation, and effusion is evident. And then they give them silicoscopes, which is NSAID, and the patient returned because of dyspnea and increased swelling in both legs and fatigue. The blood pressure is very high, blood urea nitrogen is high. From the baseline, his serum creatinine is 4.3 and his serum blood urea nitrogen is 38. His urine analysis was normal. There is no low urinary it showed low urine sodium, but no cellular element and no proteinuria. Which of the following is most likely mechanism of which NSAID causing acute renal failure in this patient? A, it's drug-induced allergic interstitial nephritis. B, acute papillary necrosis with renal obstruction. C is drug-induced tubular necrosis. D is hemodynamic renal insufficiency, and E is nephrotic syndrome. Which the answer you think to be? So I think many people picks D and A. So let us do some exclusion and then we're gonna find out the answers. So the drug-induced allergic interstitial nephritis, it's the usual interstitial nephritis have a cellular element for some patients, especially eosinophilia. So we're gonna find an eosinophilic urine or eosinophilic cast at the cause of interstitial. Also, the interstitial nephritis have many symptoms like fever, and some patients have a rash, stuff like that. Acute tubular papillary necrosis is associated with renal. The patient presents usually with a lion pain and sometimes hematuria, and also there is reduced urine volume. Drug-induced acute tubular necrosis, as Dr. Tarig told us, the acute tubular necrosis associated with high urinary sodium, and as we look down there, the urinary sodium is low. So this the above from A to C, it's not the answer. And we have just D and E. And regarding nephrotic syndrome, this patient have a heart failure, and then after using his symptom become more severe. He have a symptom like buffy lower limb swelling and stuff like that, but they have no proteinuria, so nephrotic syndrome is excluded. So the most likely answer is volume depletion from use of NSAID, because if someone have chronic kidney disease, it have a low renal perfusion, so we have prostaglandin and other things that keep renal perfused. If we start them in NSAID, that may precipitate them to develop a CKD. And also the CKD in this patient is presented with progression of his own condition, because this patient have a CKD, he have a heart failure. So after using NSAID, the symptom of heart failure is aggravated. So the answer here is B, hemodynamic renal insufficiency from using of NSAID, which is precipitate heart failure in patient of ischemic cardiomyopathy. And that's it. Thank you very much. Anyone have a question?
Thank you so much. Thank you both. This is great presentation, and it's open for the other fellows if you have questions or addition or any comments before we can jump to the next topic. You're going to see a lot of patients with kidney problems, especially if you are going to internal medicine, family medicine residency. So it's helpful to know the basics, and hopefully it will help also if you know some other people around in the community. If no further questions.
It appears like no questions on the chat.
Excellent. We can move on.
Yeah, thank you so much, Dr. Mutasim and Dr. Tarig. Up next, we have Dr. Amna. She's going to present emotional intelligence. Dr. Amna, the stage is yours.
Hello, everyone. Assalamu alaikum.
Alaikum salam wa rahmatullah.
You see my screen, everyone?
Yes.
Yes.
Yes, we do.
Yeah, I'm gonna talk about emotion regulation, skills, exercise, and strategies. Our objective today is to recognize what is emotional regulation, why is emotional regulation important, and 5 emotion regulation skills you should master, and 7 strategies that can help us regulate our emotion, and what is emotional regulation disorder, and we talk brief about dialectical behavioral therapy. So emotion are the normal part of everyday life. We feel sad like when we miss loved one. We feel angry when other person let us down. But in some time our emotion is been out of control. For some people it happens regularly and they are rapidly changing emotion, causing them to do and say things that later feel sorry about it. And this lead to damaged relationship between the friend, between the coworker. So you have to pay attention for that. They can be a number of reasons why someone lose control of their emotions. It may be genetically predisposed person to that rapid change in emotion. They may be they may never have been seen or hear about emotion regulation models or learn about how to manage or to learn the skills to manage the emotion regulation. They may have experienced trigger in negative situation that happened in the past and he got a bad experience from that, and maybe from physical symptoms like exhaustion or drop in blood sugar. No matter the reason, we can all benefit from learning strategies to control our emotions, and emotion regulation is ability to better control our emotional state. What are emotional control and regulation? It's ability to effectively exert control over our emotions through a wide range of approach. We talk about this in next slide. Some people are better at regulating their emotions than others. We see many people, we call them like they are calm person. Those person also experience like difficult emotions sometimes, but they have high expectation how to manage themselves and how to be aware in their internal experience and the feeling of others. And that about emotion regulation. We not care about our emotion but we have to take care of others' emotion feeling too. Emotion regulation skill can be learned and improved over time. Learning how to manage negative experience can benefit your mental and physical health. Why it's important? Why is emotion regulation is important? As adults, we are expected to manage our emotion in a way that are socially acceptable and help us navigate our life. When our emotion get the better of us, you can cause problem and negatively impact our relationship. Inability to control our emotion can also hurt ourselves. Feeling overwhelming sad can lower well-being and cause unnecessary suffering. Living with unmitigated fear can get in a way that affect our ability to take the risk and to develop new life experience. So 5 emotion regulation skills we should master. Number 1, create space. Emotional are happy and fast, so you have to give ourselves gift by make a pause, take a breath, slow down the moment between trigger and response. What you feel? Some people feel like they have stomach upset. Some people have palpitation. So when you know the physical symptom, can you make these symptoms lower it down and let not let that to distract you and decrease the intensity of the emotion. Naming what you feel. Many of us feel more than one emotion at one time, so don't hesitate to identify multiple emotions you might feeling, and then dig a little deeper. If you feel like afraid, what you're afraid of. If you feel angry, what you are angry about. And being able to name your emotion, you can get help and sharing your emotion with others. Number 4, accepting the emotion. Emotions are the normal and natural part of how you respond to situation. So recognize that experience emotion is a normal human reaction. The other people feel like you feel. Practice mindfulness. Mindfulness help us live the moment by paying attention to what is inside us. Use your sense to notice what is happening around you in non-judgmental way. These skills can help you stay calm and avoid engaging in negative thought pattern when you are in emotional plan. 7 strategies that can help us to regulate our emotions. Number 1, identify and reduce trigger. You should try to avoid negative emotion. You shouldn't, try to avoid negative emotion or be afraid of them, but instead you have to cope yourself with that situation. Number 2, tune into physical symptom. Pay attention on to how you are feeling, include whether you are feeling you feel hungry or tired. This factor can exacerbate your emotion, so you have to pay attention for that. Number 3, consider your story you are telling yourself. In the absence of information, you fill in the blank with detail of your own. For example, if someone of the family member not reach you or the boss not get you, you believe that they didn't care about you or you're not important for them, but you can calm yourself and ask what's the possibility. Maybe they are sick, maybe they are busy, and put yourself in their situation. Number 4, engage in positive self-talk. When emotion is overwhelming, our self-talk can be negative thought. You can, for example, you can say, I will make the wrong again, I will make it wrong again. If you treat yourself with empathy, you can replace some of this negative talk by positive comment, like try to say, I always try so hard. People are doing the best they can. This can shift the emotion of feeling to positive aspect. Remember that you can be still frustrated when a situation doesn't or isn't work, but you no longer have assigned blame or generalize it beyond this situation. Number 5, make a choice about how to respond. In most situations, we have a choice about how to respond. If you tend to respond by feeling anger and to reach that anger to people or scream with them, this definitely will be a negative impact in your relationship. Or you can feel good at this moment, but as a consequence, we feel guilt about that and painful. So try to next time to choose how you want to respond. You can, for example, you can tell someone that you are feel angry rather than speaking angry to them and get some help from other people around you. Number 6, look for positive emotion. Human naturally overweight more to negative emotion than positive one. This is known as negativity bias. Negative emotion like anger and sadness, it's gonna be louder, but positive feeling like happiness and interest are quieter. Making a habit of notice these positive experience can boost yourself and well-being. Number 7, seek out of therapist. Managing our own emotion can be difficult sometimes, so it requires high degree of self-awareness. When you become to suffer really from that emotion regulation, you may need to speak like to partner like a therapist to cope with that stress. So our next topic, what is the emotion regulation disorder? Emotion regulation disorder is a condition where someone has difficulty managing their feeling. A person with emotion regulation disorder are more likely to experience dramatic change in mood. And this fluctuation is their negatively impact on person action. Yeah, they exaggerate. It's not just like simple stress. They exaggerate it more and more. So we have example like difficult building and maintaining health relationship, self-destructive behavior, hypersensitivity, frequent meltdown, and temper tantrum. Emotion regulation disorder can also be accompanied by other mental health issues like depression, stress, borderline personality disorder. What is DBT? Is dialectical behavior therapy. Is a type of cognitive behavioral therapy that seeks to identify negative thinking pattern. Individual work with a therapist to reduce these patterns with positive behavioral change. It includes practice such as thought placement or situational role reversal. In this, we imagine yourself in situation and you try to manage this in different way. So by exercise, they can help them develop empathy and cognitive flexibility. One of the term goal of dialectical behavioral therapy is to improve the stress tolerance. With practice, they can learn how to calm themselves down and make better in solving the problem. At the end, negative emotions are a part of our daily life, and pretending they don't exist won't make them go away. Rather than try to avoid them, you should try to develop emotional intelligence and regulation skills. Building the ability to self-regulate is crucial to leadership, communication, and relationship. And that's all I have. Thank you so much.
Thank you so much, Dr. Amna. If anyone has questions, feel free to ask.
Thank you again, Dr. Amna. This is great presentation. Hopefully it will help some of you down the road. So not in residency only, but in real life and with family, friends, and so on. Thank you.
Thank you.
Thank you. Now we can have Dr. Duaa presenting resident well-being. Dr. Duaa, if you are ready.
Yes, I am. Hello, everyone.
Hi.
Okay, you see my screen now?
Yes.
So today I'll be speaking about resident well-being, as it's a very important topic for when we match, inshallah. Starting by, as we know, medical residents are integral parts of the healthcare system, but they often experience high level of stress and burnout. In this presentation, we'll be discussing the importance of well-being in medical residents and strategies for achieving this goal. First, we're going to be speaking about the impact of stress and burnout in medical residency. The term burnout by itself means it's a syndrome of emotional exhaustion, depersonalization, and reduced personal accomplishment. Burnout can lead to negative repercussions for the individual experiencing it and for people who are around this individual, especially the patients. High levels of burnout among residents are associated with perceived suboptimal patient care and decreased effectiveness and empathy towards patients. Generally, it was found that the residents' well-being overall was lower than population well-being, especially in PGY1 residents in comparison to PGY2 and PGY3 residents. And this is increased mainly in female residents as they had the lowest probability of scoring above the study population mean for well-being. They were also more likely to report frequent feelings of sadness or depression. And this was found to be more in married females who have children as well. This is a study that was done in 2015 in the general population of medical students, graduates, residents, and early physicians as well. It was found that in residents, out of 1,489 residents and fellows, 50% of those reported symptoms of burnout. And out of those 1,400 as well, 50% screened positive for depression and 8% screened positive for suicidal ideation. So it's really important to shine a light on this topic. This is just a reminder that burnout is not only in residency, it doesn't just happen in residency, it happens even after residency. And this is the latest statistics by Medscape for 2022. And it was found that, by specialty, emergency medicine physicians and critical care were found to be the most burned out. And the least burned out are public health and preventive medicine physicians. What are the consequences of the burnout? We have consequences on the personal level and consequences on the professional level. On the personal level, the consequences are broken relationships, alcohol and substance use, depression, and suicide. On the professional level, we have decreased quality of care and increased medical errors, decreased patient satisfaction, decreased productivity and professional effort, and finally, increased physician turnover. So what are the strategies to be done to promote well-being? We have strategies implemented by the program and strategies implemented by the individuals, the residents per se. By the program, it's important for the program to promote resident well-being by providing a healthy environment that gives the resident the sense of control and autonomy, the pursuit and achievement of goals and opportunities for learning, positive feedback, and positive colleague relationships. Also, it's important that the program have stress management training to the medical education curriculum that can help the trainee to deal more successfully with the stress of training. And it's important also to have regular monthly retreats. So this is a reminder to put that on mind when doing the rank order list, if the program cares about the residents' well-being or not. Here we have the ACGME requirements for programs regarding resident well-being. The first one is enhanced meaning in work. And then we have promotion of progressive autonomy, which means that the PGY2 residents, for example, they have more autonomy than interns in treating patients. Increased administrative support, attention to work intensity and compression, excuse for residents to receive medical care during scheduled work, education for residents to identify symptoms and signs of burnout, depression, and suicide, and tools for depression, suicide, self-screening, and also to continue to adhere to the 80-hour work per week and no more 16-hour shifts for PGY1s, continue with 1 day off in 7 with no greater than Q3 calls. The last one is residents can stay past end of shift to continue to care for a single patient. This has happened after a feedback from the residents that they wanted to stay more to care for one patient. So what are the strategies that should be implemented by the residents? It was found that the most important one is mindfulness, which is the awareness that arises from paying attention to the present moment non-judgmentally. And we can achieve this by meditating, doing yoga, or just going on nature walks. We don't have to do all of them, but just meditating 10 minutes per day is could be helpful. As we all know, sleep is also very important. Getting 7 to 9 hours of sleep per night is important. And for those who have night shifts, getting sleep during the day is important as well. Regular exercise of 30 minutes per day is recommended, and it doesn't have to be a continuous 30 minutes. You can just get like break it into 3 10 minutes, for example. It was found that residents who have who care more about spirituality and religion were less likely to report symptoms of burnout. And of course, as we know, family support and social activities are important to be maintained during residency and during work. So what's driving the problem? So it was found that these are the important things: the workload and job demands, efficiency and resources, meaning in work, control and flexibility, work-life integration, social support and community at work, organizational culture and values. These are the things that if they were less optimal, it leads to burnout. If it was more optimal, it leads to engagement in physicians. Put here some resources in the website of American College of Physicians and the AMA website to promote resident well-being. They have a lot of good toolkits and curriculums to learn about it, to be aware of it, aware of the symptoms, and to have the self-reflection of burnout. So it's really important to check them out. And this will be my presentation. Thank you so much for listening.
Thank you so much, Dr. Duaa. Dr. Naod, if you are ready to present infographic using Canva.
Okay, can you hear my voice?
Please. Yes.
Okay.
Thank you
Hi,
so much. Please.
everyone. So we will proceed with the presentation of infographics. I'll try to share my screen. Can you see my screen?
Yes.
Yes, it's here.
Okay. So last time, I think we had seen a brief introduction of how to use Canva graphs. So we'll go a bit deep today on seeing what infographics are. As the name indicates, these are graphs with some sort of information. And we'll try to compare why infographics is more effective as compared to PowerPoint presentation. So in case of PowerPoint presentation, you usually do it on a slide-by-slide basis. So it's a bit tiring sometimes and boring. So the advantage of infographics is you have already pre-made platform or plate so that you can put on your data and it will be easy for you. And secondly, is also color and design attractive as compared to PowerPoint presentations. Nowadays, in a PowerPoint presentation, they do have already incorporated graphs in different form of attractive way of presenting data, but Canvas infographic makes a bit color and design attractive as compared to PowerPoint. And also you can present using infographics in one platform, like 7 or 8 parameters as compared to slide by slide in PowerPoint. It's also time friendly. So last time we have seen on how to log in and create account with Infographs. So I would just simply log into my account. So what you will do is you just click here, Infographics, and will be presented with different form of the plates that will be very helpful. So today I have decided to use a data informatics graph. So I will choose this platform. It will be easier for me. Then you say you customize this template and you can start on working. So before working on any form of infographics, usually it's preferred to have a data that you can incorporate into the already prepared platform. So for today, because I think we want to condense good information in a short period of time, I have prepared a simple data that belongs to this group. So today I will try to define this group and I will try to prepare an infographics that represent this group. So the bigger point is going to be what is a telegeriatric research fellowship. So in the first part of the platform, we will explain what's the concept of this group. So this is like an online research portal system, which helps us IMG people to have research publication and introduction to research. And the second one is the aim, which is like to facilitate to matching residency and have a good introduction, especially to IMG, to the concept of research and residency persuasion. And I have added a little bit data. These numbers might not be accurate. What we should focus is on how to incorporate this data into the graph. So I have randomly selected that out of the 150 or 160 people in this group, 75% are female. And out of all the group, let's say 85% of the group members are IMG. And the second concept that we want to present is nationality. Let's say we have 30% Sudanese, 10 Somalis, 10 from Syria, 10% from Egypt, Eritrea, USA, British, and Saudi Arabia. And the next concept is a destined residency. So let's say 50% of us want to pursue internal medicine, 25 family, pediatrics, dentistry, and 5% unknown. And the last one is I have introduced a concept called what's next. So the next project is like to accredit this platform and get a certified recognition so that everybody can use this platform and use it for future purpose. So let's go to our graph now. So this is the graph that I chose to, the platform of infographics that I wanted to use. So in the heading, obviously, it's going to be the first concept, which is the telegeriatric research fellowship. So you can click here, you can delete it, and you can say telegeriatric research fellowship. So this is the main heading of this plate. While you click here as any form of Microsoft Office, you can decrease the size, the font type, the color, the background, the alignment as any form of Microsoft Office or PowerPoint presentation. You can use this. Most of us are familiar on how to text, type, and incorporate. The only new thing here is the bars in here. So when you click design, it will give you a different form of design from what I have chosen. For example, it will give you like different form of designs which are enlisted here. The design depends on what type of information you want to present. So I have early decided to present a data. For example, let's say if you want to present a platform, a progression, or highlighted presentation format, it will choose depending on what kind of format you want. So the advantage over PowerPoint is in PowerPoint, you kind of like separately incorporate separate graphs to form a big graph and a big format of information given infographics. But here you have already incorporated idea. So all you got to do is just incorporate whatever data you have and put it in the platform. The second one is you can upload from different platforms. The third one is text, project, photos, and Google Maps and chat. So because I have been trying to practice this platform for a while, all this was added by me. Let's remove this one. Let's remove chats and this one. So you will have a choice down here. Saying apps. So when you click the apps, it will give you a choice to incorporate to this part of the graph. So you have already the basic one of text, project, photos, and other choices. But here you will have, let's say, you can add emoji, you can add Google Maps, or you can add different form of, let's say, YouTube, depending on what type of presentation you want. So let's bring back the one that I was using, like generally chat. So as soon as you click chat, the chat part is added to this part of the bar. And let's bring another one. let's say audio, videos, depending on whatever type of presentation you want to choose. So let's go back to the graph that we are working. So we have already identified the title, and we have already discussed on how to work on the size, font, background. Then the next concept is, it says a concept here. And I have already a data prepared saying that this is the concept of the group or the project. So I can simply just select this one, go back here and put it here. Of course, you have to delete it. And you can increase the zoom percent into here. So I can paste it here. So already we have identified the title, the concept. So this is like using an online search portal system so that we'll have experience in publication and pursuing of residency. In this text, we are talking about three things: research, publication, residency. So let's try to remove this. This is most of like a presentation for pharmaceutical people. Let's say, because most of us in this group are either MD or have worked in any form of medicine. So let's try to incorporate a new picture here. So you can edit it here. You can decrease the size as much as you want. So we have a title, you have a concept, and most of us are represented as a doctor here. So we just try to pursue residency or publication. So the concept is all of us can write here, all of us can edit the graph. The concept is how to familiarize yourself with these bars here, what to add, how to remove, and when to use. Since I'm using like a simple one that is very informative to the rest of us, you can add different. For example, if you want to add a YouTube channel about interview of a resident, you can add a video here. But I'm trying to just incorporate the simple that I made into this so that will be easy for all of us to understand. And there is like, what is the goal of medicine? So I can delete this one and say that the concept of the group. So for example, I accidentally deleted the text format here, but I can still incorporate a new text saying that add a subheading here. So the subheading will be here, and you can bring the subheading. Sorry. Here, and you can delete the title, and you can say, let's say, aim of the group. And we have already prepared text format for this one. And okay. So we have heading, we have the concept, we have a young physician picture incorporated in this, and we have a title by the head of aim and the aim of this group. While doing this, if you click here, you can change the text format to different, like you can change it to here, the size, you can increase it or decrease it. The color, you can make it whatever color you want, whether it bolds, whether it's like italic, like a normal form of Microsoft Office. Now, the next concept is how to incorporate graphs, percentile, and this one. And in the previous graph, we said that 75% of this group are female. So let's incorporate that concept into here. So in the statistics, I can ask, let's say, I can type, let's say, gender. So we have 75% of this group, 75% of this group are female. So we go to chart in this case. Let's say, let's include this chart. So when you click here, it will give you like a pie graph. You can delete this one, you don't need it anymore. And you can also delete this one. So we want to incorporate this one. So it will give you a number, percentage. So in this group, we have agreed that 75% are female. Okay, and this line weight explains the weight or like how shaded the graph is here. So this is a bit too big. Let's say, let's make it a bit thin. Okay. And the percentage level shows the 75% you want to incorporate into the graph. So you have to say like, show the percentile here. Then you can increase the size. You can delete this one. You can delete this one. And you kind of like put it here. Let's say you have gender title, 75 percentile, but you want to include something here as a text. So you can say like text, add a little bit of a body text, and just say you can put it here. I hope everybody's following. And you can delete this one and say that to be more informative, the rest 25% are male. So it will be a more attractive graph. So you have a gender, 75% saying that female, the rest 25% are male. In the statistics, I will incorporate the other one, which is like, let's say 85% are IMG. So you can still go back to the chart. And you can choose this one. And you can put this one 85. And you can decrease this one and show the level. I want to delete this one's more appropriate for the sex and gender, so you can show like this percentage are female, this percentile are male. You can still incorporate this graph into this concept by saying, let's say if you click here, it will show male, female, and you can decrease the trends. Let's say in the previous one, like 75%. We just try hypothetically to assume like 75% are female. Then you can incorporate this graph into the other platform. But now we have already done this one, so we'll try to include like 85% are only IMG. So you can delete. And you can also delete this one. You can put it here. Here's the size. In the statistics, you see, you can put like text. The body, you can include IMG portion or presentation or percentage, whatever. So we have incorporated a picture, concept, aim, gender distribution, IMG distribution. Now, from the data we have already presented, we are done with this one. Now we want to, let's say, hypothetically, you want to represent nationality. You can click here, let's say. Nationality. So we have already prepared a data. Now we will try to incorporate a different form of graph so that will show what kind of nationalities we have. So let's choose this one. So when you choose this one, you have different bar graphs represented in different form. You can include whatever item you have here. So for example, the first one is Sudan. The second one is, let's say, Saudi Arabia. The third one is UAE. The fourth one is USA. The fifth one is, let's say, Britain or UK. You can manipulate whatever number you have. So let's say, let's put it 30 here, which is 60, 10, 70, 80, 90, and let's make this one 20. So we have a graphic representation of the members of this group, like in a different graph. So let's decrease the size here. And you can put it on the side of the nationality. So as you see in this graph, the countries which are represented are a bit shady, but this one is a bit big. So you can still go back and edit the text. So let's say, you can increase the text so that will be a good representation of whatever picture you are doing. Still, we can delete the syringe and the syringe and the tablet because they are not part of our presentation. So by using this tool, we have already accustomed ourselves how to present like a pie graph or different form of graph. From the chart, you can choose whatever you want. Let's say you can choose this one. So that all you gotta do is just incorporate whatever data you have from your sheet or from Access, and then you can present it in one graph. If you feel like you don't need this added graph, either you can delete it or you can simply use the undo button of Control plus Z, that it will go away. So we have already included the nationality. Let's do a deal. The last one's destined specialty preference. And let's say we add a different picture for this one from the pixel. So, by the way, for example, in the gender, we have 25% female, right? You can easily include like a female letter here. It's like a simple editing. You can put whatever you want in the graph, is in the side or in the right, it doesn't matter. But it will be like more informative and more attractive. So you'll have like the rest 25% are male, but 75% are female. So this platform allows you to choose different format. Then we are talking about specialty. Let's try to find a picture that defines specialty, like a doctor or someone's scrap, or let's say this guy. So let's delete this one. Let's put him here. Now we want to include the specialty preferences. So we will need a different graph. Let's select from, let's say, this one. In item 1, like previously, you can use internal medicine, emergency medicine, or pediatric, whatever you prefer, and you can fill up the preference of the group which wants to join the specific specialty. After you do that, you will show like how many of us want to join a different specialty depending on the data we have. Then obviously you will try to adjust the font, the color, the size, the animation that you want to do. So just for convenience perspective, let's delete this one. And the last one is, I think we are left with one task. Okay, what's next? So this is like the summary. So usually like a conclusion autograph. So let's say we can choose a photo that explains whatever, like summary, conclusion, or arrow, or finish line, whatever you want. So that will be like graphically represented. Or you can still choose from the pixel, like someone running to the end, or finish line, or athlete, whatever. So let's say someone like having a step, which means like next step in your life. So you can still choose this guy, put it here. And you can include the text from this one. So accredit this platform and get certified recognition with AMC further develop of this platform. So you can just simply put it here. Delete the other one. So that will be. Then I guess you can see it. It will not look attractive. The concept is just how to incorporate whatever skill you learn from the infographics into one whole frame picture. So if we were supposed to present this one in PowerPoint, it would have taken us probably an hour, maybe an hour and a half. They have to choose different format. But here, you have more options to explain your point in one graph, but with more condensed and precise and easily capable and easily understandable concept to your audience. So when you see this one, like you see the title, you see what's the concept of this group, you see what's the aim of the group. You have an idea that most people involved in this group are doctors. Most of them are female, and the huge portions are IMG, and the huge portion, let's say, are like Sudanese. And the next group is, the next concept is just to move forward and do something. So this is like a simple and easy way of using the Canva infographics, but you can still add. This doesn't only apply only to medicine. Let's say, depending on what form of specialization or what form of profession you have, you can include whatever. You can include AutoCAD, emojis for Instagram, YouTube. Different form of platforms that fits your profession. So that will present it like in 2 or 3 slides, what would hypothetically take you about an hour and a half. Then you can either share it, copy a link, download it, or share it on social media. And you can still also import files from different storage units, either from your computer or your flash card or whatever form of storage you are using. I hope I made this one clear. Thank you everyone for listening.
Thank you so much, Dr. Naod. This is great tutorial, and I hope everyone benefit from this excellent presentation. Thanks once again.
Okay, thank you.
Thank you so much, Dr. Naod. This was our last topic. If anyone has question, or we can jump to the projects update. If anyone has any updates, please jump in.
So I have a suggestion. If by tomorrow, end of the day, if any one of you can help, or all of you, maybe we can practice on what Dr. Naod presented about the telegeriatric. You can work individually or you can work in teams. You can just build similar to what he was doing. You can use telegeriatric research publication website. I'm gonna share that with you guys. Let's try and do that now. So, and the link, I share it in the chat. So hopefully by tomorrow, every one of you can work on getting some form of print out or file, and let me know how it went for you. Thank you. Regarding the projects, anyone with new ideas, any suggestions? Any
Hello, Dr.
updates
Nadir.
as far as next? Yeah, go ahead.
Hello, everyone. Just I wanted to share with you that our INR application was successfully published on Glide Template Store as a free template. So for my colleague fellows who are interested in translating this application into other languages like Arabic and Spanish, you can easily make a Glide account, copy the templates, and start the translation process. And many thanks to Dr. Nadir and my team members for their support. So if you have any questions about how to copy the template and how to start, I'm available. Thank you so much.
Dr. Nadir, you are mute.
Thank you. Thank you so much, Dr. Amal, for sharing this with us. This is great news and excellent work. I congratulate you and your team for this excellent project, and it's a big deal when it's been accepted at Glide App. It's a big company, international one, and it has its own known reputation. So this is great. Hopefully it will help you and your team. And as you mentioned, there is always room for improvement. So for other teams, other members who are interested in doing similar projects, they can work at least with the translation part, or we can start working on new ideas like building new apps. And the next step, as we were discussing, how we can improve it to make it also accepted at the Google Store and Apple Store. So this is the highest bar that we need to overcome. But so far, you did great. Excellent. Thank you, Dr. Amal, and your team.
You're welcome, Dr. Nader, and thank you very much for your support. We had a very good time actually working on this application.
Thank you. So again, just to let you know, we are accepting new applications and new fellows. So the website, we shared it last time. So if anyone who's interested can apply through that website. I can share it with you again. So in the chat, the website for, if you know someone who's interested, please reach out to them and they can upload their information. We will start the interview process later in February. So thank you. Dr. Nafisa, I don't see her here, but she and her team work on, oh, Nafisa is here.
Yes, I'm here, Dr. How are you?
Very good. How are you?
I'm doing great.
Excellent. Can you share with us your good news about the abstract, Amna?
Yes, actually, at the beginning, they just accept both of my abstract for the first review only. And for the second review, at the beginning, I accepted only one. But I'm so grateful that they accept the second one later.
Excellent. Congratulations to you and your team as well. So we have at least 2 abstracts accepted at Amna. Do we have any? Excellent. Congratulations. This is good news. Any other Amna news? I think we submitted 5 in total, if I'm not mistaken. Anyone from other teams know anything about other abstracts submitted? If you know nothing, that's fine. If anyone knows, please let me know, update me. Can shoot me an email or text. Thank you. So we will be working also on new projects in the coming days, weeks. So whoever interested in joining and working on new projects, let me know. So we can assign some project leaders and then members, and then we can identify tasks and divide the task between the team members. All right. Any comments, any addition, anything you want to share before we close this meeting? All right. I'd like to thank all the presenters from today's presentations. Thank you so much. You did great. And I'd like to thank Dr. Sulafa for moderating this Zoom meeting. Thank you everyone who attended, and thanks to those who will watch the recording later. Thank you. Assalamu alaikum. See you next week.
Thank you so much. Have a good
Thank
day.
you, Dr. Nader. Thank you very much for your help and support.
Assalamu alaikum, everybody.
Assalamu alaikum.
السلام عليكم.
وعليكم السلام ورحمة.
السلام عليكم.
عليكم السلام ورحمة الله.
السلام عليكم.
وعليكم السلام ورحمة الله. دكتور أسامة.
عليكم السلام دكتور نادر، كيف أحوالك؟ الله بخير.
الحمد لله بخير. How are you?
الله يسلمك. الحمد لله بخير.
How's family? How's Dr. Azza?
Yeah, she's fine. I will be the moderator for the next week.
Yes.
Instead of Khila, she had some. She will be absent next week.
Sure. So we
All
have the agenda, I think, for next
Okay.
meeting. So
Okay, I will check them and I will reach out for you.
yeah. So oops, I think I will share the wrong one.
All right.
Okay. Thank you. See ya.
وعليكم السلام.
Assalamu alaikum.
Assalamu alaikum, Dr. Nader. Sorry, I was just away from my phone. I'm not sure if Dr. Shema reached out to you or not, but our abstract also got accepted with Amna.
Alhamdulillah, very good. Congratulations, Dr. Ryan. If you can share with me the email that you received or they sent from Amna, that would be great.
Yeah, so they said they're going to publish it in their journal as well. So
excellent.
It's great news for us.
Alhamdulillah, congratulations, you and your team. So the next step is to work on identifying who will be there or who will be working on the poster itself. And
yes,
so
absolutely. Absolutely. Jazakallah khair. Thank you so much for everything. Really appreciate it.
No problem. Thank you.
Of course.
Excellent.